Well, good afternoon. Hopefully I'll wake you up a little bit more because that meal was so good that I feel a little postprandial. We're going to be talking about epidural fever. And epidural fever is an interesting question. I would argue one of the most interesting questions in obstetric anesthesia right now. And hopefully by the end of this talk you'll agree with me and agree with the reasons why we need to do more to look into whether or not epidurals cause maternal fever. I have no financial disclosures, and I'll describe no off-label use. So let's start with a survey. How many audience members believe that epidural labor analgesia is associated with maternal fever? Raise your hand, yes. Okay, hands down. Raise your hand, no, if you believe epidural labor analgesia is not. So we have a few. Okay, so we're starting in the right direction. One more question. Raise your hand if you believe epidurals cause maternal fever. All right. Raise your hand if you're not sure about the causation factor. Hey, you guys are way ahead. All right, nobody needs to stay because that's about where we're going to be. Got it. We're going to critically review this literature. We're going to review the consequences of fever in labor. We're going to theorize on mechanisms, discuss prevention and treatment, and finally propose the next step in studying this association. Well, when we study associations, there's lots of different types of studies we can look at. We can look at observational studies in which women choose their analgesia. These could either be retrospective or prospective. We have randomized controlled studies in which women do not choose their labor analgesia. They're randomized typically to epidural in one group and IV opioid in another. And this may be for the entirety of their labor, or it could just be for early versus late in labor. And finally, we have before and after studies in which epidurals are introduced into a practice and we can see what happens to the rates of fever. So let's back up just a little bit. This is the first temperature curve that was published. And if you look here, this group down here in the solid bars did not have epidural analgesia, and this group with the open circles did. And it was, at this point, it was just really a curiosity that this had happened. And nobody thought much of it, but I thought, well, maybe we should look into this a little bit more. And subsequently, this curve was published by Dr. Kamen and Sanjay Datta at the Brigham and Women's Hospital, and essentially what they looked at is here again. Here's these solid numbers. These are the women with intramuscular or IV pithidine or meperidine, and these curves here are women with epidurals. Now, interesting, one of these groups had epidurals with fentanyl, and one of them had epidural labor analgesia solutions without fentanyl. They both developed fevers. The first curve, they were actually looking at vaginal temperatures. And this group had said, you know, maybe the reason that the vaginal temperature increased was because of the sympathectomy that occurred below the epidural. This study, however, on this curve right here, actually used tympanic temperatures. So both vaginal and tympanic temperatures were increasing. I know you probably can't see this very well here, but I'm going to walk you through this slide. This is a table that I made with one of my mentors, Dr. Scott Siegel, and where essentially we've gone through all the observational studies. Remember, those are studies in which women request and receive the epidural that they choose. Here's the author. Here's the year those observational studies were published, what they defined as fever, which was typically 38 degrees, the percentage of fever in the epidural group, and the percentage of fever in the non-epidural group. And I want to point out these p-values. All of them are significant for differences between the epidural and the non-epidural group. Every one of them. So there's a clear conclusion from this table. Women who choose epidural labor analgesia are more likely to develop a fever than women who do not. But there's problems with observational studies, right? There's selection bias. Infected women, women with chorioamnionitis, have more painful labors. And those with long and complicated labors are more likely to request an epidural. Finally, obstetric practice can be influenced. Obstetricians are not biased. And so they're far more likely to perhaps do more manual exams on women with epidurals, or maybe they might give greater amounts of oxytocin to those women. There's another problem that comes in when it comes to observational studies, and this is something, a problem that Laura Getzel has termed an averaging artifact, and we're going to explain this. So essentially, Laura Getzel published this curve here, and the thing I want to point out with this curve is all these women, both groups got epidurals. The difference is this group down here remained afebrile throughout labor, and they had no significant change in temperature throughout. But this group right here is the 20% that developed a fever. So here's where the epidural was placed. These 80% remained afebrile, and these 20% of women became febrile. So in other words, she showed that 20% of the population it accounts for the entire phenomenon. How this can be looked at is the previous curves that we saw actually are an average of this curve and this curve, of the women that don't and the women that do. And what I would argue is that this group, this 20%, is the group that we need to be studying, not the group that remains afebrile, the 80% that remain afebrile and have no increase in their temperature throughout labor. So that comes to this study, and you all remember this study published in 2012, and essentially this was a prospective study that enrolled 90 women. And what they were looking at is they were looking at temperature of these women, and they looked at the curve of temperature from when these women were admitted, began labor, had their epidural placed, continued with labor with their epidural, and then finally delivered. And the argument here was that if epidurals actually caused an increase in fever, you would expect to see an increase in the slope of the temperature over time curve after that epidural was placed. And they did not. Well, this was curious, because this was another observational study. These are women that requested and received epidurals. They all got epidurals. And it didn't go along with what we'd previously seen. The media, however, loved it. Epidural anesthesia does not increase maternal temperature during labor. UAB study says epidurals do not cause fever in women in labor. Epidural analgesia is not to blame for fever in laboring women. However, I think we have more questions than we do answers from this study. And what I want to show is this part right here. And essentially what this says is in the methods section, we excluded patients with medical conditions that would affect temperature regulation or the normal course of labor. And then they go on. The normal course of labor, particularly chorioamnionitis. And then they went on to say, the diagnosis of chorioamnionitis was based on a combination of fever, temperature more than 38, or a combination of at least two of the following findings. So they eliminated women that developed a fever. But interestingly, they went on to say in their results that they only eliminated one woman for chorioamnionitis, which is even more confusing, because how could they have only had one in all those 90 women when all the previous studies have shown sort of a 20%? So a lot of more questions than answers, but essentially, according to Laura Getzel's work, they eliminated the 20% that defined the fever. So previously, we thought all women with epidurals had gradual temperature elevation. However, the current thought is 20% account for the entire phenomenon, and they have a robust and immediate fever that is significantly greater than their baseline temperature within an hour. The other 80% remain afebrile, and essentially what we need to do is study the 20% that become febrile. We cannot have studies that eliminate that 20% and expect for us to discover anything further about the phenomenon. So, we know women who choose epidural labor analgesia are more likely to get a fever. But that doesn't tell me causation. Just because something is associated with something doesn't necessarily mean causation. We see that all the time in OB anesthesia literature. So what's our next way of looking at causation? Randomized controlled trials. Control for everything else and look at your primary outcome. Well, here are the randomized controlled trials. The key here is primary outcome in all these studies was specifically, besides this de-orange study at the bottom, these other studies were specifically looking at the epidural's likelihood to cause cesarean delivery, and they happened to also report temperature on women, okay? So fever and temperature were not primary outcomes in this. And here's the authors, here's the year, here's their design of all randomized controlled trials. I'll go on a little bit about this design. Definition of fever, greater than 30%, greater than 38 degrees. Epidural group, 22%, 24%, 20%, 33%, 14%. Okay? Non-epidural, all less than 10%. P-values, all significant. But there's problems with randomized controlled trials, right? There's dropout and crossover. And one of those studies I show you was not analyzed according to intention to treat. So what can happen is that complicated and infected labors can cross over from the epidural group and fast to the non-epidural group, and fast and easy labors cross out of that epidural group into the IV analgesia group. And that's a huge problem. And analyzing according to intention to treat can help. So in other words, you just analyze them into the original group in which they were assigned, and that helps account for that somewhat. Further, obstetric practice may still be influenced. So even though you can randomize women to one group to the other, you cannot blind obstetricians as to whether or not a woman has an epidural. They're just too good. Epidurals are just too effective. And this is the main thing. Only one of the 5 randomized controlled trials had fever as its primary outcome. And that really matters, because when we do a randomized controlled trial and we're looking at an outcome, we control for everything else around that outcome. So they were trying to control for anything else that could have caused a cesarean delivery. They weren't specifically controlling for anything else that could have influenced a woman's temperature. Tylenol administration, room temperature, number of blankets, ice chips, so on and so forth. None of that was controlled for in those studies. All right, so let's move on to the next type of study, before and after studies. This is a retrospective cohort looking at 1 year before versus 1 year after epidural use. What you would expect to see is if epidurals caused fever, more fevers after the institution of an epidural practice, and that's exactly what you see in this study. Before, in this Yancey study, 0.6% of women reported fever in labor, after 11%. That gives a relative risk of 18.3. Pretty significant, huh? So observational, randomized controlled, and before and after design studies all support the association between epidural labor analgesia and fever. Darn. Well, what else can we look at? When we look at causation, we can look at dose effect, right? And when we look at dose effect, we can look at early versus late CSCs or epidurals in labor. So in other words, if epidurals cause fever, you would expect to see greater fever in women that labor longer. In the Wong 2005 study that we all know well, essentially in her early group in which combined spinal epidurals were placed at less than 4 centimeters dilation, and the women labored for 440 minutes, and compared to the late group in which epidurals were placed late in labor and women labored shorter time, 330 minutes, had the exact same Tmax between the two groups. So there was a difference in neuraxial analgesia length, but there was no difference in temperature between the two groups. Likewise, the Wang study, which was published in 2009 and randomized 12,000 women to early versus late labor, saw that difference as well, where there was a huge difference in, in the length of labor, 12.6 hours in the early group, 4.8 in the late epidural group, and the T averages that they reported were exactly the same between the two groups. So there is no dose effect. The longer a woman has a labor epidural does not increase her likelihood of developing an intrapartum fever. All right, so let's see, where are we here? Well, on the yes side, in the question of whether epidural labor analgesia causes intrapartum fever, we have all these observational studies. We have 5 randomized controlled studies of varying quality, and we have a 1 before and after study. And in the no side, we have early versus late epidurals. Okay, we're going to ask the question on causation. At this point, how many people, these are the studies, how many people think right now epidural fever or epidurals cause fever in women laboring? Raise your hand if you think they cause it. Okay. How many people think they do not cause it? And my third question is, how many people aren't sure? How many people think the question is still out? Yeah, I agree. I totally agree. And so looking at the literature, we have a lot, but I think the weight of the evidence is currently supporting at least an association. We know it supports an association, but whether that means causation, not sure yet. Well, before we move on to the consequences of epidural fever, to kind of reinforce why we need to study this more, I want to remind everybody of where we were with cesarean deliveries in the mid to late 90s. I would have been in about high school then. Anyway, just trying to make y'all feel a little older. That was really mean. Back then, my understanding is that there was a time when people really believed that epidurals caused cesarean delivery. And there were a lot of things that kind of lent themselves to that. A lot of even randomized control trials. There was a number of studies that looked at that. But not until we started studying it the right way with the appropriate primary outcome did we actually come to the answer that epidurals do not cause cesarean delivery, right? I think that's where we may be with epidural fever. But we've really got to look at this closely. And I say maybe because I still think they could definitely cause. I just don't know how. And we're going to get into that, these potential mechanisms, in a little bit. But before we do that, let's talk about consequences. Why does this question matter? If a woman develops a fever, she's more likely to require intrapartum antibiotics. She has an increased likelihood of cesarean or assisted vaginal delivery. And for the fetus, they may get some neonatal septic workup. They may or may not get additional antibiotics. That's related to the institution's neonatal practice style. But this is what's worrisome. Fetal hyperthermia is associated with low fetal tone, low APGAR scores, bag mask ventilation, tracheal intubation, supplemental oxygen in the nursery, cardiopulmonary resuscitation, and neonatal seizures. In this retrospective cohort study by Greenwell took low-risk term nulliparous singleton pregnancies. In the epidural group, essentially had about 20%, here we go again, 20% of their epidural group developed a fever. In the no epidural group, it was about 2.4%. And in patients in which there was no fever at all, there was no difference in fetal outcomes. In patients with epidural analgesia and a temperature above 100.4, there was a linear trend between Tmax and all neonatal outcomes examined. So here, these are all women, had a fever, low risk. Blue is 99.5, red is 101 degrees, and you can see this significant increase in percentage of babies with transitional hypotonia, hypotonia greater than 15 minutes, the requirement of assisted ventilation, 1 minute APGAR scores less than 7, 5 minute APGAR scores less than 7, and even a slight increase there that you could see a trend in seizures. Darn. So it's a problem. It's something we need to get to the bottom of and even figure out how to treat and prevent. But what's the mechanism? Could it be high ambient temperatures in the room? Perhaps. When I walk into a room of a woman that is laboring without an epidural, what is she? She is naked. She is on her hands and knees. She's panting. She's sweating. One nurse has a washcloth on her forehead and her husband's feeding her ice chips, right? She is dissipating heat. When I walk into one of my patients' rooms that has a well-functioning epidural, she's usually sitting like this. She's not moving a muscle. She's got 2 blankets on. She kind of rolls her eyes to look over at me to describe a little bit of pain that she's having and how she needs some more analgesia. And she's, right, she is not dissipating heat. And in fact, she looks like she's retaining heat. And the room is hot often. So it could be that. It could. We need to study it as a primary outcome for that reason alone, because we see such a huge difference in heat dissipation practices amongst women, behaviors amongst women with and without epidurals. There's also less hyperventilation in women that have epidurals. Women with epidurals may have some increased heat-producing shivering. They may have altered thermal regulation below the level of the block, including an elevated sweating threshold and altered thermal regulation of the brain as well. There's some questions if there could be some antipyretic effects of the IV opioids that women that don't have epidurals. Mu opioids have been associated with decreasing fever. But the mechanism that looks most interesting and probable is this idea of non-infectious inflammatory response via pro-inflammatory cytokines. So a non-infectious chorioamnionitis is kind of what it looks like. And this is the best proposed mechanism. And it looks like these women that receive epidurals seem to have an exaggerated response in comparison to women that do not have an epidural. In this Riley's 2011 study, we won't get into the details of it, but essentially they found that among women who had an epidural, those that came in with an elevated IL-6 level at admission were more likely to develop a fever than those that came in with low IL-6 levels. This implies that maybe there's a subset of women that are primed for an intrapartum fever, and an epidural sort of unveils it. They have a different infectious profile. There was not a difference in these women when they didn't have an epidural. And again, they found, just to say again, it was about a 20% epidural rate. All right, well, if it is non-infectious chorioamnionitis or inflammation, this theory is not good for babies. We know that intrauterine inflammation results in fetal brain inflammation and neurotoxicity in mice. We know that even subclinical placental inflammation causes fetal brain injury in animals. And in humans, the link between intrapartum infection and cerebral palsy is well established. But we don't know what the contribution of inflammation is and what the contribution of infection is and what the contribution of hyperthermia. And if it's inflammation and hyperthermia, maybe we're causing neuronal damage. So how do we treat it? Well, active cooling does not work. Women do not like that at all. Prophylactic antibiotics have been unsuccessful. And that was another study that was done in 2014 that we'll talk about tomorrow. Didn't work. Anti-inflammatories, Tylenol doesn't work. Not surprising, it's not a very strong anti-inflammatory. And pilot epidural dexamethasone study decreased IL-6 levels but did not reduce fever rates. But high-dose steroids, it worked. High-dose steroids worked. And essentially, this study showed that at the time of epidural placement, women were randomized to one of three groups: placebo, 25 milligrams of IV methylpred, and 100 milligrams of IV methylpred every 4 hours. Holy smokes, right? Well, look at this. Fever, 21%, 22% in the placebo group, 34% in the 25 group, and in the 100 IV methylpred every 4, fever was 2%. We did it, right? High-dose steroids decreased the incidence of epidural fever by 90%. But that's not the end of the story. The rest of the story is in those three groups: neonatal bacteremia, asymptomatic neonatal bacteremia, 0%, placebo, 2.1%, 9%. Remember, asymptomatic neonatal bacteremia kills babies. Well, that didn't work at all, did it? But perhaps that study tells us a little bit more about the mechanism and the role of inflammation, with dexamethasone being such a strong anti-inflammatory. So here we are. That's what we know about epidural fever. We have more questions than answers, don't we? Is it that an epidural has pro-inflammatory effects? Or perhaps effective pain relief blocks a naturally occurring anti-inflammatory process? And if that's the case, can we reproduce this without harm? Is there a group of women primed for epidural? Can we define who those women are, identify them, and then actually counsel them against epidural analgesia, or at least counsel them to wait as long as possible before they get their epidural? Is there a least pyrogenic epidural cocktail? There's a bit about intermittent dosing versus continuous dosing. Does proactive labor management, placing that epidural and kind of being off to the races and really trying to get that baby out as fast as possible afterwards, to decrease any consequences? Well, I think, and I hope you learned from this talk, that I really believe that we need to embrace the possibility that this phenomenon is real. And we need to move good quality research forward because it's important that we answer these questions. Thank you very much.